Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Welcome to another episode of a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. My name is Stephen Shaffer, and I'm honored to introduce to our listeners Dr. Mark Laslett. Dr. Laslett graduated as a physiotherapist from Otago School in 1971. He is a former manipulative therapy instructor for the New Zealand Manipulative Physiotherapists Association, as well as its president in the 1980s. He has been an instructor for both AUT University and the Mackenzie Institute. Dr. Laslett has over 35 scientific publications. He authored the book Mechanical Diagnosis and Therapy, The Upper Limb, and was the first physiotherapist to be board registered as a clinical specialist in New Zealand. Dr. Laslett continues to practice as a board-certified specialist in physical therapy, during which time he sees complex patients. All of these points aside, they are just a small part of what Dr. Laslett has accomplished in his professional career, and I would like to point out, perhaps most importantly, that he completed his PhD from Linköping University in Sweden in 2005. The reason that's of particular importance to us today is that his dissertation was based on the diagnostic accuracy of the clinical examination of patients with chronic low back pain and referred lower extremity pain. Dr. Laslett, welcome to the podcast. How are you doing today?
Very well, thank you. Let
me say to you, sir, that it is an honor to have you on our show.
We will see.
That's a hindsight 2020 comment
That's
there.
Fine. No, I'm honored to be here. It's great.
Excellent. And, quick side story here. The reason this conversation came about is because in my role as a faculty member at High Point University in North Carolina, I saw a student of mine perform a technique that was attributed to Dr. Laslett, and I thought there were some errors there. I'm sure this is the type of thing that happens across all professions and all sorts of techniques. When I started diving into the resources with my students in the room, and we're all finding different things, we found conflicting information out there. So I went right to the source himself, got some clarifying points, and, fast forward, here we are.
It is common to have those particular tests performed in a variety of ways, most of which have never been researched.
Yes. Yeah. One of the things that I like to point out is the fact that if you look at the actual clinometric data, there's some utility here and there, but unless you package it in a bouquet of, 10 or 20 or 50 other variables, it's pretty much meaningless.
Absolutely.
So another related point, as I mentioned in the introduction, your dissertation involved referred lower extremity pain, and hopefully I was slightly prepared or more prepared because of the fact that I just gave about 3 days ago a lecture on referred pain. And hopefully we don't find out in this conversation that I misled my students by giving them all false information.
I'm sure you did not.
So, Dr. Laslett, the primary reason that we brought you here today was to talk about the lovely and ubiquitous term nonspecific, which I think you and I both have an equal disdain for.
Well, disdain is maybe not quite the right word. It is a dinosaur, certainly, but it had its place in the 1980s when it was discovered, and it was published, I think, 1987, with the Quebec Task Force on Activity-Related Disorders, that basically diagnostics in low back pain and sciatica had not reached a stage where doctors could agree on what the patient had. And so it was better to lump these things together into one sort of catch-all phrase, which they called nonspecific low back pain. And then people like Waddell, he was asked to give GPs advice on which patients orthopedic surgeons wanted to see. And he used the phrase as well. So it's become popularized. But to use it in 2019 as though it were a diagnosis is definitely dinosaurial. It's just the science of diagnostics got started really in the 1990s, and there's been 20 years of fantastic amount of research. And to say that we cannot diagnose is simply erroneous. To say that most patients don't get a diagnosis is actually correct. But just because a person doesn't get a diagnosis because the examinations are not done does not mean to say it's not possible. So non-specific means you haven't made the attempt.
That's an absolutely beautiful way to recontextualize my comment about it being something that I disdain. And, in terms of your mentioning of the historic timeline, I agree completely. I will admit, however, perhaps as being a year or two younger than you, I didn't fully appreciate the Quebec Task Force or 1986. But in preparing to talk with you about this, one of the ththings I did do was go back into PubMed, which is, one of the search engines I use most frequently for health research. And, I wanted to go back and see how far I could go and how much this term was used. And between 1920 and the 1960s, there were almost no references. You could start to see the term creeping in the 1970s, but it wasn't really used in reference to topics like pain and musculoskeletal healthcare. In 1980, there were 26 results. 1990, 48 results. 2000, 186 results. 2010, 413. And this was a search for nonspecific combined with pain. And then last year in 2018, there were 620 results. So part of the reason I think that's important is because the primary message you gave was this word is old and no longer has a place, but these trends say that we continue to use it more and more and more, even though we should perhaps be using a different diagnostic approach.
Well, even if you don't want, some people are unhappy with the idea that of making specific diagnoses, and although I disagree with that, I respect that opinion. The reality is that non-specific still has a place, and that is what happened. That when a patient walks in the door, at that point they are non-specific. Because you haven't even examined them. You don't even necessarily know what their gender or what their age is. So you know nothing about them. So they are non-specific. But as soon as you start to acquire information, the specificity starts to sharpen up. And I think that saying some patient is non-specific is a profession of ignorance. And ignorance is okay. I mean, that's where we start. But to say that that's a permanent state, I think is an intellectual mistake.
Yeah, I like that distinction between, where the patient is in the process and how we think about them or label them. And, one of the things that it makes me think of is the fact that patients come to our clinics in a whole wide variety of ways. So, for example, in the clinic I work, they might call up and, be a direct access patient. So they speak to somebody at our front desk and the patient doesn't know. So they just say, I have low back pain. It makes sense for the person at the front desk to write down low back pain or non-specific low back pain, even if they got sent to us by someone else. Imagine a situation where they're referred to you by a non-musculoskeletal provider. Maybe they're a medical provider, maybe they're an internist, maybe they don't have any skill set in that realm. It makes sense for them to use it as well, but not for me and not for you.
Well, if you profess to actually be interested in back pain or any particular area of pain, like shoulder pain or knee pain or whatever, if you happen to express interest in that and that is what you treat and that's what your job is to try and make sense of this non-specific complaint, then to categorize a person as non-specific, this means that you have examined this patient and cannot find a reason why they are hurting. Now, that's still a legitimate endpoint because there are patients for whom we do not have an adequate explanation. But that is uncommon rather than common. And I think that that's the thing that we have to be clear about.
So it's the exception to the rule, not the rule.
It certainly is not 90% of back pain, or it should not be.
Agreed, 100%. A situation that makes me think of was my last clinical affiliation when I was in physical therapy school. And, I didn't know as much back then as I do now, so it's not so much a comment on myself, but just a general type of situation. We had a patient who we tried and tried and tried and couldn't make better. We tried, everything that we were ever educated to implement. And on the last day, this is the day we were going to discharge him for lack of progress. He came in and all of his back pain was gone.
And you have no idea why.
I had no idea why. My clinical instructor had no idea why. So the logical question is to ask the patient, what happened? What's changed? And he said, I was in the emergency department last night because I passed a kidney stone. All right, that makes sense. That explains what we saw before here, before now.
I've only ever seen one renal colic, and I will never forget it because this patient moved around the table so fast and in such agony, yelling and screaming. I knew this patient from previous episodes of back pain, but this was nothing like I'd ever had before. And he moved like a patient like no patient you've ever seen with back pain. He was moving fast. He was moving rapidly, trying to get away from something. You could tell it, and he was in agony. And the doctor, I just happened to be in the medical practice at the time, doing a clinic with another doctor. And one of the doctors there just had this. He said, "Oh, look, I've got such and such in here, and he's one of your patients. Do you want to have a look at him?" And I said, "Sure." So I go in there, and there he was writhing like a snake. And I says, "This guy hasn't got back pain. I think he's got something else." I said, "Is this what I've never seen before, renal colic?" She says, "Oh, God, of course it is." So, I mean, yeah, unless you've seen it once, it will be a mystery until you realize that back pains do move in a certain way and not like that.
Yeah, and at this point in my career, I'd like to think I'd not treat the guy for whatever, 6, 7, 8 visits, but I haven't seen it lately, so I'm not sure. Moving on to the next thought that I had, I'd like to hear you talk about the general term itself, low back pain, which if we think about anatomy, physiology, all the psychosocial variables that we might include in our diagnostic process, it seems to me that the word nonspecific, of course, is nonspecific, but then so is the term lower back pain. What are your thoughts on that?
Well, according to the International Association for the Study of Pain, low back pain means any pain between, I think that's like the lower ribs and the iliac crests and lumbar and the sacrum, basically. And it is a symptom. It's not certainly not a diagnosis. And so in that sense, it is quite specific. It means pain in an area, just as shoulder pain is pain in the shoulder. I wouldn't regard that as a non-specific statement, but it says nothing about cause or source. Now, those two things, by the way, source and cause, are quite distinct parts of the etiology. The source is like which structure, the pain generator. The cause is why that pain generator, well, that's tissue or structure, is actually producing nociception. And that is, again, quite distinct from the experience of pain. And nociception is not pain. Pain is a brain output. It is possible, theoretically anyway, to get the experience pain without nociception. But I think extremely uncommon. And most of the time there is some pain generator or some nociceptor receptor activity that is being interpreted by the central nervous system and consciousness as noxious. And that is what the pain experience is. Then you have the downstream effect of that is, so how does this pain experience affect this individual person? They're all separate questions. To try and lump them all together and say pain is a complex thing and we must embrace the complexity and all that sort of stuff, fine, but you need to break it up into these components, conceptual components, to be able to understand how the whole thing is put together as a complexity. And I think this is a really important part of the discussion.
I think that's an absolutely spectacular response, and it's exactly how we try to approach the situation here in my job. One of the things I've noticed over months, years, etc., is that we tend to use these labels kind of willy-nilly. So, for example, we say low back pain for a whole host of reasons. One, it's the terminology the patient uses. Two, it's the terminology that the referring providers utilize when, in fact, there are referring providers. It's the terminology used on, for example, commercials when they're trying to sell you a product. It's a term used when people are trying to apply for something like federal disability status. And here in the United States, it's specifically a coded diagnostic term that's utilized for things like payment and reimbursement when you're working with a patient who has insurance. So regardless of how, someone like yourself or myself or anyone else thinks about the different subcomponents and how they relate to each other and how we can use that content to, say, perform a thorough evaluation, find what seems to be some sort of thing that we can address, and then try to make a patient better, that process just gets lost in the ubiquity of different people saying lower back pain.
It's just a broad term covering a symptom. And you could say exactly the same thing about abdominal pain, chest pain, knee pain, shoulder pain, or ankle pain. They are coded for various uses in everyday life. But when we are talking about people like myself and others and just yourself who focus on trying to understand this particular patient with that symptom and what are we going to do about it, then it takes on a much more specific meaning, or should do anyway.
With respect to that meaning, can you attempt to paint a picture for our listeners, for example, how you picture, and we'll just keep going with this theme of low back pain or pain in general, whichever is best. How do you approach it? How do you think about it, contextualize it? How do you formulate it so that you have the type of diagnosis that allows you to evaluate, treat, and then hopefully improve your patient's condition?
Fine. Look, how I see things is that I'm always looking for the two aspects, source and cause. And then there's a third part, which I call confounders. So source and cause. Source is the pathoanatomy, the actual origin of any nociception, should there be one. And I believe in most cases there is. Then the cause of why that tissue or structure actually is being active in a nociceptive sense. So those two things are what I call a pathoanatomic diagnosis. The patho being the why, the anatomy being the where. Then you have what I call the confounders. You and I and everybody who's involved in the pain industry knows that pain is an individual, unique experience, an experience unique to the individual. And there are people who downplay pain, who literally almost ignore it and just push through it. Most professional athletes do this all the time. They have to. You can't be a top-line athlete and not experience pain. In fact, pain is the measure that you're pushing yourself hard enough to remain in the top tier. So to them, pain is almost a good thing. They will exercise until they hurt badly. All right, that's how they become good at what they do. Then you have that's one end of the continuum. The other end of the continuum is the person who the faintest hint of a nociceptive input is a tragedy. All right, is the sentence of death, and they just will not tolerate any discomfort. And they run off to the doctor for the first little hint of a snivel or a cold or a paper cut. These the whole spectrum is there, and the next patient walking in through the door could be anywhere on that spectrum, anywhere. And you cannot treat the pain experience as being generalizable to all people. It's just not possible to do that, and you shouldn't do it. And all the pain experts tell us this is the case, and I totally agree. But there is still a pathoanatomic foundation, and then we have to deal with that individual in pain. It's not a matter of saying, oh, I'm a pain person versus a reductionist pathoanatomist. I don't see myself as either or. I see myself as treating the individual who has a pathoanatomy and the personality and psychosocial mix that I have to deal with as a construct because I'm dealing with this person who comes to me with pain. And so that's how I see myself as a clinician and as a researcher. I can't divorce the two. It is wrong to divorce the two aspects, the confounders like depression, like fear avoidance, like kinesiophobia, like catastrophization. All these things are confounding not only treatment effects, but particularly diagnostics. We have shown in our own research that patients who are classified as distressed according to the DRAM instrument, that's the stress risk assessment method. If they're classified as distressed, then diagnostic accuracy declines. And we also know that those same people also are harder to treat. And it's the same with people who are classified as severely disabled, like according to the Roland-Morris questionnaire. If they are severely disabled, diagnostic accuracy is also diminished, not dramatically, not so dramatically as you'd think, all right, but it is diminished. And also we know that those patients are harder to treat. Now, so the whole thing needs to be seen in that light. I get often accused of being a reductionist pathoanatomist, and I really resent that because that's not how I practice. It's never been how I practice. I'm fascinated by the pathoanatomy. It is true. But that's not how I behave as a clinician. I am a clinician of the person who happens to have a pathoanatomy that I'm fascinated by.
I think that was really well said, and I can hear some of the, low levels of frustration coming through in your voice there. And honestly, I've had the same experience. I do like to pay attention to pathoanatomy a lot more than some of our contemporaries who sometimes I think go too far down the psychology rabbit hole. We go there. We test in our clinic for depression, anxiety, pain self-efficacy, general self-efficacy. I bring all these other variables in.
And you should, and it's great that you do that.
Thank you. And that's just the beginning of the list, but boy, do we do a bunch of biomedical markers as well. The evidence is out there about the prognostic indication from someone's grip strength, regardless of what their problem is. We test 2-minute walk tests. We test their lung function. We're really trying to throw all these different components.
You do more than I do.
So,
I have a very simple procedure. I have patients do an online series of questionnaires for back pain or for most pain, but I see mostly back pains these days. But and these questionnaires, I do pain VASIS. I do the Roland-Morris questionnaire because it's simple. I use the central sensitization inventory. I use the DN4 for neuropathic pain, and I toyed with the OSPRO YF, which was put out by George et al. Quite recently, and it's a great idea, but I'm not sure it really influences me that much. But I've played with lots of these sorts of things, and the patient does that before I even see them, and then when they first arrive, I get them to do pain drawing. So I put a lot of store on pain drawings. Actually, I think it tells us a lot. It excludes many things. When you do a pain drawing, or when a person has pain all over the body, you're not dealing with just back pain. I do all of those things, but I don't go into these a lot of those biomedical markers that you've just been describing, unless there's some reason to go down that route.
To me, it sounds like your approach is sufficiently thorough, and of course, the true judge of that are perhaps the long-term outcomes that you're getting with patients. And of course, there's more than a way to arrive at the destination. In our particular case here, it's an approach that my colleague, Dr. Garrett Nays, mostly helped create. And, to a certain extent, we don't know the utility of everything
Sure.
we're doing. Like anything, you create an idea, you try to make it evidence-based, and now we're implementing it, and we're going to try to see which things work better, which things don't work as well. And then, we're constantly adjusting and tweaking, and, hopefully in a year or 50, we have some better ideas of what's going on.
Well, I think that we are rapidly approaching the time in history where the technology is sufficiently sophisticated that we can start accumulating in the clinic at primary care level, not at secondary, but primary care level, data that will be stored permanently in a format that can be used in the future for retrospective analyses to compare with prospective analyses. And I think that this technology has existed for a while, actually, but it takes a long time to implement that in a way that is research friendly. But I've long been an advocate of accumulating data on patients, in a way that is stored and can be retrieved for later analysis. And it's like big data on the individual.
It's definitely big data, and it makes me think, of course, and I don't know if this is global or if this is just in the US, but every time a physician diagnoses cancer, they collect all sorts of information: age, sex, zip code, type of cancer, stage of cancer,
comorbidities.
And, having that, absolutely. And it allows you to, in the long term, for that individual patient, maybe it doesn't help much. But in the long term, you can look at these data sets and figure out, okay, farmers are having a really high rate of cancer. So maybe it's the chemicals we're using, or there's a cluster over here and it's not far from what was a former industrial site. The problem I'm having in my head right now is, I guess, two. Problem number one, do we have enough consistency in musculoskeletal healthcare to try and implement that? And two, even if we have a good method or approach, can we get, enough people to agree to implement it?
Well, this is I would say, a growth industry. I think that the answer is we have the instruments. I don't think there's any question about that. We have more than enough in the way of instruments to measure many domains of this experience we call pain. So that there's no problem with having instruments. In fact, we may have too many. What we have now, because most offices, at least in the Western world, are computerized, we have the technology capable of collecting that data in a way that can be accumulated. But we have ways to do that, and I think that we are rapidly approaching a time when that is going to become quite simple to do. I think Mark Wernicke, for example, he still works very close with Photo, I think it is, and they've been doing work like this for quite a long time, and they've got some impressive data sets. I think that that was probably one of the early good attempts at this approach. I think that they have led the way, and I think that in this respect, and I think that we can follow that example and make that even global. We back in the when I was still part of the McKinsey Institute, we did some research that was done cross-nationally. Several projects were implemented throughout the world in various clinics in the world simultaneously, collecting the same data. And so a lot of that early research in the 90s from folk in the McKinsey Institute actually was multinational, multi-clinic, multi-site, but not just in one country or one city, but we're talking about across the globe. Now, then you're starting to get a handle on what really is out there. And I think that is so much more possible now than it ever was.
Technology certainly agrees with you on that. Of course, it has to be implemented the right way and interpreted the right way. But I mean, even it's like science, you might not implement it perfectly the first time. You might not analyze it perfectly. But as long as the genuine effort is going into it and over time you're monitoring, improving, adjusting, then, I don't think there's any reason that we can't make that happen.
Totally agree.
So based on the things that we've talked about thus far, I don't necessarily see any conflict between your approach to the diagnostic process as well as treatment, and then, the term, and you've used this term yourself, I think, or maybe it was me, but the biopsychosocial approach. Do you think that you're viewing that type of approach just a certain way with certain, scaffolding or framework, or do you think that model needs to be abandoned?
No, I don't think it needs to be abandoned. I think that the biopsychosocial approach or concept is entirely legitimate. I think that it merely recognizes the complexity of the pain experience, and I think that that's perfectly reasonable. Because I'm fascinated by the pathoanatomy doesn't mean to say I ignore the rest. It just means that I have a fascination, just as those who are deeply into pain neuroscience education for patients. They're fascinated by the psychology and the neurophysiology of pain. And fine, why would I have a problem with that? It's not particularly my interest, although I can't ignore the fact that there is good evidence to support it, good evidence that underpins the notion that we should be giving people lots of good information and avoiding bad information, et cetera, et cetera. So, but to me, the pathoanatomy and the psychosocial, it represents the full picture, or at least as much of the picture as we now understand it. And so the biopsychosocial concept captures that complexity, I think, and that's fine. Nothing wrong with it.
Yeah, I have the general same impression about the biopsychosocial model. My only contention, and this isn't with the model itself or with anything you've said, It's just that I think some clinicians fail to fully understand the different subcomponents. So, maybe their viewpoint of the bio is too simplistic or the psych is too simplistic. And the one I see ignored the most is the social. But in terms of a label, a 3-part label, I think it gets us going in the right direction.
Well, it's a bit like, I think the right way to view that, it's a 3-cornered stool, and you take away one of the stools and the stool falls, one of the legs and the stool falls over. The whole construct, the whole picture must include all 3 aspects. Now, clearly, I like to present the biopsychosocial thing when I present as a Venn diagram, all right? We have one circle for social, one circle for psychological, and one circle for bio, which is the pathoanatomical component. And they overlap to various degrees, or you might say that one aspect is the dominant thing that you have to deal with today. And sometimes that's the psychological, sometimes it's the social, sometimes it's just pathoanatomy. So how you evaluate your patient tells you what you need to do today. And tomorrow you might have dealt with, for example, the patient's fear issues and all that sort of stuff. Then you can get on with the pathoanatomy, etc. So you can morph and change your approach with any individual patient according to what you're seeing from a day-to-day basis based upon those different components. And I think I have no problem with that at all. It's what I do, I would say, habitually, really.
Well, your reference to the Venn diagram is definitely speaking to the geek in me, and I couldn't agree more.
Yeah.
So one of the questions that we like to ask our listeners is, what would you say to a physical therapist that was considering fellowship training?
Any basic physiotherapist who wants to specialize in orthopedic manual therapy ought to undergo a fellowship program. It's the only way that you're ever going to become proficient in that area of practice. So, if you want to specialize. One of the things that I find is interesting is that here in New Zealand, the basic physiotherapy program is a 4-year program and it leads to a bachelor's degree. Well, in the United States, the basic level, I think, is a master's, and in some places it's a clinical doctorate. We don't even have a clinical doctorate in New Zealand. To be a specialist, to even apply for specialty status in New Zealand, you have to have a master's degree, which is a further minimum of 2 years and a whole bunch of clinical experience. Whatever it is that you have, then if you want to become better informed on how to deal with musculoskeletal or practice, then you should get advanced training, no question.
I couldn't agree more. And you made a bunch of ideas and other questions and whatnot pop up while you were giving your answer, and you ended up giving most of the answers that I was going to ask anyway. I know a lot of countries have the master system in place, and not that it's that important, but just a quick correction for especially international listeners when it comes to the U.S. We legally in the United States of America can still acquire a master's degree to sit for our licensure exam, but all of the programs have converted over to the entry-level doctorate. There is no route in our country to get anything lower than a doctorate degree in physical therapy.
Is that so? I didn't realize it had gone that far. Okay.
Yeah, it's definitely gone that far. The last year that you could get a bachelor's was 2002. And it was sometime thereafter when the last program converted over to a doctoral program. And that was, I believe, in 2014 or 2015. Technically, the last one was in San Juan, Puerto Rico.
Right.
So for you, compared to what I went through, the advanced masters in New Zealand or Australia or somewhere else would be equivalent to our fellowship process.
I think so. Yeah. But in New Zealand, yes, that master's degree that you get is just a degree out of the university. It is, it allows you, gives you the academic rigor and the breadth of academic understanding, so that you may therefore then go on to apply for specialty status. We have yet to develop an internship program. It's still very new in New Zealand, but we have yet to develop a program that takes you from your master's into specialization. All right, that's That is yet to be implemented. Frankly, it's just not financially viable at the present time. Again, we are talking about a country of 5 million people and only 4,000 physiotherapists. So the actual marketplace is pretty tiny compared to what you're so accustomed to in the United States. So we don't have the economic grunt to focus money in a way that you guys can do that in Europe and in North America. So we've yet to develop that further, and we are doing that.
So as we're coming to a close here, let me ask you, do you have any forthcoming projects that we can expect to see from you in the near future?
Absolutely. I have three. The first one is that we are developing the Spanish version of my online education program. And hopefully that'll be available for Spanish speakers in 2020. Currently it's in French. Spanish is the next. And I'm doing my first foray into the Asian area. I'm going to Taiwan in April. So I don't know what will happen out of that, but maybe Mandarin is another option as well. The second project is that I've just initiated the discussions on a research project comparing clinical variables with magnetic resonance spectroscopy. It's a new way of looking at images, MR images in the spine that has the potential, and it's only potential at this point, to identify symptomatic discs. It doesn't measure, unlike provocation discography, it doesn't measure, it's not a mechanical test, which provocation discography is. It is a test of the chemistry. And there is a chemistry that seems to be related to discogenic pain. So we are looking at trying to design a research project on diagnostic accuracy of the clinical examination and other confounding variables in relationship to that reference standard, which is going to be non-invasive, expensive, but non-invasive compared to provocation discography. So that's a research project. And there's another paper that my good friend and colleague, Flavio Bonnet in Paris, has pushed me into putting down on paper my idea of diagnosis by subtraction, which is fundamental to the methodology that I use in reaching a diagnosis when we do not have a positive high specificity test. Now, I won't bore you with the details, but basically when you have a highly specific test that's positive, then the diagnosis is made and the patient can no longer be said to be nonspecific. That happens in a minority of cases in back pain. But then when you don't have positive, highly specific tests, then you are left with excluding things, saying that it can't be this, and it can't be that, and it can't be another thing, and it can't be that. So therefore, the only thing that can be is X. And that's what I call diagnosis by subtraction. Now, I do have 2 public domain videos on YouTube that look at that. One is a free, it's an older version of a lecture that I give on my course, but it's in the public domain, and it's on diagnosis by subtraction. And there's another one that I was a tongue-in-cheek one I called Diagnosis of Back Pain as Child's Play, which is also on YouTube. And it illustrates the mechanism by which we actually do, and expert clinicians I've seen all over the world that use this method, they say, well, if the patient doesn't have leg pain, we can rule out ridiculous symptoms. If the patient only has midline pain, we can rule out facetogenic or sacroiliac joint pain, et cetera, et cetera. And so there are many parts of the evidence that tells us we can say that this is not the problem. So if you can do that in a systematic way, then you can rule out stuff and be left with either a single diagnosis or at least a lower number of possible diagnoses that need to be explored from a pathoanatomic perspective. Now, this paper that we are putting together I've basically written the structure of it, but now we have to mathematize that. And that is the process that we're going through now. And I'm hoping that 2019 will be the year that we'll have that paper ready for submission to a journal. So those are the 3 major projects that I'm engaged in the next 12 months or so.
Well, those sound like the type of projects that we should keep a lookout for in the future. Thank you for sharing that with our audience. And can you just give me a quick list of where listeners can find you? I know you already mentioned YouTube, but if they want to look more into Dr. Mark Laslett, where are they going to find you?
YouTube is not a good place because there are many people who have put up videos of particularly the sacroiliac tests, and they call them the Laslett cluster, which I find is interesting because I didn't invent most of those techniques. But anyway, that's fine. You can follow me on Twitter. I'm there. I think it's at Mark Laslett _NZ. And we also have a couple of Facebook pages. My professional Facebook page has a lot of videos, and I regularly post to that. I spend maybe an hour a day on Twitter, and I regularly post to my Facebook page. And then there's the Facebook page of our English language online learning platform, which is called Southern Musculoskeletal Courses. So that's www.musculoskeletal, or one word, .courses. So it's www.musculoskeletal.courses. And that's our homepage. And you can find lots of information on myself and also my colleague Angela Cadogan's courses on that.
It sounds like you might be more on the web than I am, and that's okay with me. So I will make sure we link to all of those places that you can find Dr. Mark Laslett. And I guess the last thing before we go is, Dr. Laslett, I would like to thank you for being here. It's been an honor and a pleasure.
Thank you so much for inviting me, and it's been a pleasure to talk to you folk.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.